So can you open the PowerPoint of the pulmonary valve presentation now? Open the PowerPoint. Yeah, please go ahead.
So that counts as 2 cases.
Okay.
No.
Steve, if you feel you need to go to the bathroom or get a glass of water in between, then feel free, because you're putting the rest of us to shame. I would have needed a 3-hour lie down after that case.
You're going to take one now, aren't you?
Just watching it.
Shaq, are you still hearing me? I am moving to the next lab.
I'm afraid so.
Yeah, so I will read out the story because it's a 72-year-old man. Give me a glove, please. 72-year-old male. He's a tetralogy fellow, operated. Arun, you have to move and show me the PowerPoint. Yeah, the tetralogy fellow operated at 31 years of age in 1983. He was one of the earliest tetralogies that was operated in our country. If you know the history of open heart surgery in our country, it basically started somewhere in the mid 70s, and towards the early 80s was just about 100 or 150 patients who were operated. This was operated by one very big surgeon by name Stanley John, who was in Christian Medical College, Vellore, and it was one of the centers that was doing a tetralogy surgery during that time. So he post-operatively, he had an infundibular residual gradient of, show the first picture, infundibular gradient of 25 millimeters, because there was a protocol of checking post-operative cardiac catheterization in those days, and echocardiogram was not available in CMC Vellore in 1984. And so then he is now progressing with effort dyspnea worsening due to increasing RVOT obstruction. He also he's a very hypertensive patient on multiple drugs. He's actually on olmesartan, cilnidipine, eplerenone, and I think one more antihypertensive, and he indapamide, 4 drugs, and he's a known diabetic. He's on medications. He's hyperlipidemic on medications. He's an asthmatic on inhalers. He has heart failure with elevated JVP. He has got a loud stenotic and regurgitant murmur. His NT-proBNP was markedly elevated. Next slide. So he's still in sinus rhythm, and in fact his ECG shows that there is not much of right bundle branch block that we normally see. Probably the resections were in an area where it was not anywhere near the right conduction system. He has got a minimal upper thoracic scoliosis, mild cardiac enlargement. Next. Echocardiography, it was no, go back. Echocardiography was of extremely suboptimal windows. If this movie can play, you can appreciate how much muscle bound RV was, how much severely hypertrophied. CT scan shows, next picture, CT scan shows, this is a diastolic frame. You can see that there was a tight infundibular stenosis, an extremely muscle bound right ventricle. In the leftward picture, retrosternally, you can find the right ventricular outflow tract calcified, and that calcium was actually very close to the posterior table of the sternum. That the radiologist's opinion was that when you do a sternotomy, you will actually open into that calcium, that area. So this is the systolic frame, quite a tight infundibular narrowing. You can appreciate on the rightward last picture how much the infundibular muscle narrowing is there. Next picture. Here, this is a virtual reality which Pramod is very fond of. It's done during the Vimersive platform, which is by the Poland company. So he has put in a virtual stent there. It is a 5 centimeter long stent, and actually he has given a proximal flare. He has flared it in the right ventricular infundibulum to 27 millimeter. So he planned it out with virtual reality. Now today when we entered, actually this patient also, little bit of hemodynamics were done a short while parallelly when we were in that mitral para. So he had a right ventricular systolic pressure of around 80 with a RV gradient of around 50 millimeters of mercury. This is the RV pressure, and the RV pressure on the top. Next picture. So what we did was, now let me show live echo. Okay, so actually he had coronary atherosclerosis on the CT. So we did a fluoroscopy. There was a lot of calcium in the LMCA, LAD, circumflex, but fortunately LMCA, proximal LAD, mid LAD, and circumflex was good, but the distal LAD was having multiple levels of narrowing. We decided to just accept it. Next picture. Then we looked at the right coronary. Right was difficult to hook. Finally, when we saw right coronary also did not have, like, there was some mild atherosclerosis, but not an extremely bad atherosclerosis. So then the next picture. So we did an angiography. The lateral view angiography showed that, what is this ACT? Just check on the ACT and 330. Okay. So the lateral view angiogram showed an RV diameter of around 18 millimeters. This is the muscle bound infundibulum, and we were using the fluoroscopic calcium that is seen on the anterior wall of the RVOT as the proximal end of the stenosis. Next picture. This is an epicranial. In epicranial, we can appreciate the muscle bound narrowing below the third wire and above the fourth wire. So this was a tight infundibular stenosis. So at this point, what we decided was, basically he's a 72-year-old man. 72-year-old man, we were not thinking about redo surgery and all, and there was already a sternal calcification which was considered to be closer, even though here it is moving. The calcium is moving. Calcium is not adherent to this posterior sternal bone. But anyhow, at that age, with hypertension, diabetes, hyperlipidemia, surgeon was not very much interested at all. So our intention was to stent it out. Now this is a very controversial thing, because infundibular muscle we are now stenting. How good the stent will be, how much the stent will collapse, become bad. So this was some of the questions that we had. So now what is your thought process, Shaq? Shaq, Gareth?
Let me pick on Mario for this one.
What do you want to know?
He's got a stent in position across the infundibulum. Proceed, or would you have concerns?
Oh, I think that based upon this picture, the position of the stent is good. The expansion is okay. Well, interestingly enough, we see the calcified coronary on the behind. That's the left coronary completely calcified. Yes.
Mario, what about stent selection?
Well, the issue of stenting a RV outflow tract with muscle is that the concern is that sooner or later it will break. That's a concern, obviously.
So Mario, what stent will you use?
If you want to have a long-lasting stent without fracture, probably we need to do multiple stents implantation. So I would suggest to have a look at the stent, if there is a recoil, if there is an impression of a contractile muscle around it, and considering to put another stent inside before putting a valve in.
Kevin, would you put a covered stent in or a sequential?
I think you can even put two PAMAs in at the one time. You can mount them on top of each other and go up through your sheath, and that saves you time, because it's always a bit more difficult getting back. I'd agree with Mario that you would need a minimum of two PAMAs here to be anyway happy.
Just wonder actually whether or not a way to do it would be to put two PAMAs or two Andra stent or two LD Max and the valve at the same time and just nail it down like that. I think that's a possibility.
Anybody put a covered stent in?
No, I don't. I wouldn't. I don't think there's any need here for a covered stent at all.
Okay. And then the concern I think Shiva was probably alluding to in this was a possibility of arrhythmia once you've stented and put a valve in place.
That's another possibility, yes. Don't know.
Yep.
Difficult to predict.
You get arrhythmia, then you have to treat it.
So basically the points that we considered, we wanted a closed cell design stent because that will be the strongest stent. An open cell like an intrastent max or something will be a little weaker, because open cell is definitely weaker. And among all the available like closed cell stents, one of the strongest is still the old PAMAS XL, say 5014 or 4014, one of the strongest stents. We had a plan of putting in two stents, one not sequential, not at one go, but get me a.
So, Shiva, I was asking Alison about to try and address the point about arrhythmias following infundibular implantation of stents and valves?
Oh, I think you'll be able to ablate through the stent that you just put in. But what about putting in a nice strong frame like your MyVal inside a couple of palmas and not having that fairly flimsy CP framework?
Get me the Zephyr stent opened out. So basically what we did was, I will now show the live, Surya show the next stent. So what we have got it is now, this is a Palmas XL 5014 mounted on a 22 into 4.5 centimeter Z-Med balloon, and we expanded it in the location of the right ventricular infundibular muscle.
Shiva, who inflated this balloon?
I inflated, Shaq. Anything wrong?
No. It was.
Okay.
I thought it was too slow.
Okay. Next picture. So then we this is the full inflation. Then next what we did was we looked at whether there is any recoil. Next picture. Actually there was not much of recoil, but still in order to get it reinforced, I put in a Atlas Gold balloon 22 into 4. Show me the next. So this was an Atlas Gold 22 into 4, and that was also fully expanded. And show the next. So this one, actually the valve continued to remain at somewhere around 21 to 22. Next picture. Then we made a couple of angiograms, and this is the wide open stent. Next picture. So this is the AP cranial projection. Next picture. So at this point what we wanted was, the proximal end was obviously not fully attached, like not adherent to the RV wall. So give me the Zephyr stent. Give me the Zephyr, open. What we did was we proximally opened out with a coda-like balloon the proximal portion alone, and I got it flared a little bit better. So get a dilator, quick, get a dilator. So actually I flared out the proximal end a little bit more. So now you can see that the proximal end is getting little flared. Show the next picture. Next, Surya, next. Yeah. So now what this is the proximal portion. Now we have got it little bit more enlarged. Now show me the next. Yeah. Next. So the proximal end we got it now almost around 27 millimeter. So I should be able to like push in my ensemble. The intention was not to go overboard by dilating it much larger when I can fracture. I know that the Palmas XL's maximum good diameter will be 25, and if it goes beyond 25 it may fracture. So I stopped it at 22. Arun, can you do a live fluoroscopy, epicranial? So parallelly what I am doing is I am mounting a Melody valve 22 millimeter ensemble, and I am covering that Melody valve with a Zephyr stent, so that it is a one-step second stent. So what I'm going to do is,
sorry, you're putting in a Zephyr stent, yeah?
No, first was Palmas XL. So this is a
Palmas. Okay,
this is a Palmas XL. So but Zephyr is actually more of a open cell in the middle and closed cell only at the edges. So it is not a very strong stent. So I wanted a completely closed cell stent. So the options were either a CP or a Palmas XL, and I had a strong belief in Palmas XL because it is supposed to be a little bit more stronger than a CP. CP being a welded stent carries a risk of fracture at the welded points, whereas Palmas being a laser cut, the chances.
Let me just ask Massimo, would you do a Melody plus a Palmas stent on top, or a different stent?
Can you keep flashing?
So I think that Palmas is the right choice in this specific case, I believe.
What
You have it available in Europe.
No, we have not yet this stent available, but I think it's a very strong one. It's probably a very good one to fix it in the RVOT in India.
And Radwa in Bristol
Pressure.
or UK?
Well, we don't have the Palmas
Show
anymore,
this,
so
please.
we
Show
would
this
probably
other
be
camera.
mounting STP in
Show the
Bristol
other
just 'cause
camera.
That's what's readily available.
Yeah.
Yeah, Shaq. I mean, and
See, what we are doing
Siva,
is
this
a
is-
one-step melody and Zephyr together. So these two
Yeah.
are now going to go inside the previous Palmas XL. So now the melody
Yeah,
has been made. So now I will go and change the.
Shiva,
Yep.
quick question for you.
Hello, Mark Roos from the Netherlands. Why was it so obvious not to put in a covered stand at first? I don't understand, because there was calcification. It's an older man, so why not?
It was not calcification on the infundibulum. It was a calcification in the. Get me the RCA catheter. Right coronary
Very
catheter. It was not
important
a
question, that.
calcium in the infundibulum. It was a calcium in the right ventricular anterior wall pericardial patch. Show this lateral
You
view
can't
again.
predict where the rupture will occur.
But we were
Well,
planning
if
to
it-
stent it. We were planning to stent it above the. You see that my position of the stent is above the calcium.
Shiva,
Yep.
Shiva, is the stent you've mounted on the Melody, is that a Zephyr or a Palmas?
Zephyr. The first one was a Palmas. The first one, Palmas, is already deployed. Now I am.
Maybe my English is not very good, because I said on the Melody, is it Zephyr or Palmas? And he said, oh, Zephyr's not strong enough.
No. Sorry, Shaq, I will make it clear. The first stent was Palmas. And the second
Yeah.
stent is a Zephyr.
Yeah, I mean, Siva, what you're demonstrating here, I think, is really good. This is like when we put a melody in, which is pretty rare these days. We co-mount two LD Max, which is a similar strength stent, on top of the melody, and we try not to pre-stent. Just put two chromium stents on top of the melody, mount it all together, and put it in the ensemble, and put it all up in one go, and it seems to work fine. So I think this is actually a really good way of avoiding having to recross multiple RVOT stents and catching your delivery system and all that sort of stuff. And it also brings the procedure down to about a third the time. So I think this is a really good demonstration.
So what sheath are you going to put? I daren't ask this question now. No dry seal, obviously. So what sheath are you going to put the
I'm going to-
Melody plus the
I'm go-
Zephyr stent?
Yeah. So what we need is, the Melody system is a 22 French system. So I need at least 22 French. But 22 will be very tight. So I'm taking a 24 French in the groin. It's a Cook short sheath. Now, Cook's short sheath, don't pull it, just hold it here.
So you're not worried about, Damien, any worries about the passing a
Get a
bare
dilator.
stent and valve assembly across the tricuspid valve?
Shaq, if you'd listen,
It's
if
a melody
you'd listen,
valve.
Shaq, he's got it in an
It's an
ensemble. If you'd listen.
But he's got a, oh, right, the whole
ensemble.
thing.
It's a total
All right, but
ensemble.
I'll-
I'm fully
right. I thought
protected.
you'd gone a direct balloon.
No.
But any concerns about bare stents passing across?
Yes, I think the incidence of tricuspid valve damage is not insignificant. And sometimes with these cases, we have used a 22 French dry seal, 65 centimeter to get us up there. And then the 22 ensemble will pass through it. And it means once you're in position, you're going to get your valve up. So we've done it that way too.
So
I've got
now
an example tomorrow or day after about
I need a
exactly this
dilator.
point.
No, I need a artery forceps. See, basically what I did was I dilated the groin with a short 24 French short dilator. Now I'm going in with a 24 French Cook short sheath. Take your hands.
Yeah, I mean, Shaq, I think that's a really good point. Yeah, it has to be, I think in our practice, it has to be covered by something. So it's either an ensemble or a dry seal.
Yeah.
And like I said, you can get two bare metal stents onto a
tight.
melody valve inside an ensemble without increasing the size. So it's doable, and then you still get it covered.
The reason why I was laboring the point is I've been sent a couple of examples of using the ensemble for this sort of indication, and somewhere along the line accidentally uncovering the valve assembly, and then you're stuck in the tricuspid.
That's very naughty.
Okay, so basically I am going to take the entire ensemble fully covered, protected, open it, fully protected, so that hold the wire, so that I don't touch the tricuspid valve with my this one at all, any part of the stent or valve. The ensemble is going to completely protect it, and then once I have crossed the valve, then I will unsheath the ensemble and open it out in the very conventional, usual manner how it is going to be done. Can you get that melody now ready? Ensemble ready? Yeah, get it inside.
Blue to blue and white to white and all that, yeah.
Yeah.
I've lost count. Is this case 3 or 4?
Okay, if
there's
you
three
add
stents.
mitral paravalvular leak and to the other one as one case, then this is
Yeah.
2.
It's 3. This is 3.
He did an
Fourth, isn't it? 'Cause you-
atrial septostomy.
Yeah.
And then
Okay, show the center of the.
Stenting of the outflow.
like a
Very
rat
good.
up a drain pipe.
Yeah, very good.
Okay, go to lateral view, please. Lateral. Okay, so see, basically, I would like to stent in this location itself. The reason being, the distal part I have not over dilated. It's only the proximal part that I have over dilated. So if actually the valve gets deployed more in the distal part, I'll be more happier. So at present, I am going to do, since there is a clear landmark, I am going to use, there is connect an indiflator. Why you? Okay. So now I am
you
going
haven't
to.
uncovered yet.
Yeah. So I'm going to unsheath.
That was your fellow's mistake, wasn't it?
No, not just mine. Shaq, that was mine. See that the time is running, Shaq. I have to do a sinus venosus. So you are actually
no
putting
rush,
me into a
no
lot of
rush.
stress. Okay, get me a contrast. Contrast quick. Contrast.
So take your time.
Yeah.
We've
This
got
is not
all day,
diluted
you've
contrast.
got
I
all
want
night.
concentrated contrast. I don't want diluted contrast. Come. Yeah, get it. I'm going to inject through the side arm of the ensemble to confirm that I have unsheathed fully.
If you don't trust the this is a serious question, Siva, you don't trust the black dots on the balloon. You feel you need to check.
No, this is important to double check it for yourself, isn't it?
Now the inner
There's no
balloon is
marker
in.
on the
Now
black
go
dots
for the outer balloon.
Oh, outside. Yeah. But
The shoulders on the balloon are relatively forgiving, right? So you can usually, even if you're not center mounted, you get a little bit of leeway. Although
keep
this
going.
one's kind of,
Yeah, keep going.
it'll go.
Keep going. Keep going. Okay. Tell the number. 6. The cardiac output may fall transiently, don't worry.
Yeah.
Okay. So this is,
Siva,
I'm
you
recording
gonna
now
let
the
this balloon
fluorostore this. Okay, now it's
Are you
still
going to let the
deflating.
balloon slide forward as you let this down?
because the distal part of the stent.
I will do that. I'll just push it. Actually, I am planning
Yeah.
to post dilate with a 24 Atlas so that I get a little bit more larger valve size.
Yep.
I think we had this debate at a prior picks about whether people favor post-dilating these valves after they go in, and it was sort of a back and forth. I think a lot of people, it was kind of a mix of both strategies. Some people prefer to really prep your outflow tract and then put the valve in and not do anything after that. That's been my approach.
But here you're going to have to do something to that distal.
Yeah, you got to hit the distal, and you could use the bib to open that up. That'll open up with a bib.
Let's let Siva, because it's just folding a little bit there, so we just let him concentrate on this.
The problem that I am having is the ensemble balloon is not expanding easily. Can you
Yeah,
keep
it's
it pushed inside? Pushed inside. I'm now. I'm
Got winging now.
Yeah, I mean it's a flagged balloon, so
Tell me the number.
if you're going to post dial it anyway.
Tell the number.
It's doing the same thing.
Okay. Fine. So now, okay, the BP is little low, but hopefully it should pick up. Let me see. It's taking a long time. What was the dilution? 1:4. Okay, thank you. Okay. So now I will wait for the balloon to fully.
Are you planning at the end to check the coronaries at all? Or,
Coronary I have already done, Shaq. I showed you the LMCA, the LED were all normal. Okay, this right ventricular outflow tract was nowhere near the coronary.
Yeah. It was such a long time ago. I
He's
forgot.
just trying to distract you as you try and get this nose cone on. You focus on what you're doing. Shaq's just being difficult.
So I am actually trying to get the ensemble out.
Well done.
Okay, Atlas Gold 20. Yeah, get a 24 itself. Let's give a good dilatation.
Then are you planning 24 Atlas by 2 or 4?
4. I mean, it's easier to center a longer balloon, Shaq. It's difficult to center.
Yeah.
So get a quick 24x4. On the back side, indiflator plus 1 10 ml syringe. 20 ml syringe, both with diluted contrast with a 3-way.
Can you hurry up a bit?
I'll do that, Shaq. Actually, the other lab.
It's all right. I was only joking.
No, I know
We'll
your
beat 'em
time
up for you.
constraints. Thousands of cases that are being shown in the CSI, and I'm trying for getting this Atlas Gold across. So primarily, I'm going. I will first target the distal end.
Yeah.
Okay. So now I DR now. Maybe I can show you the DRing. So what I do is, can you show the camera here? Can you show the camera here? So hold it like this. Okay.
This this Zephyr stent.
Yeah.
Just clarify, number 1 Zephyr, but more importantly, distal cells are closed or what?
Correct. Distal cells are closed. The last one row alone is closed, and the proximal. The proximal. Tell the number. Tell the number. 2. 3, 4. Okay. So now I am deflating. I will come proximally. The distal part is fully dilated.
That looks better, doesn't it?
I'll try to get a little proximal. The balloon is still not fully deflated. So now at this point, I'm going for the middle. Tell me the number. 4, 5, 0, 2, 2, 2, 2, 3, 4, 4, 5, 6. So I'm stopping at 6 fluorostor and show this again. Get me 2 pigtails, or else the right coronary guide catheter will take a pullback. The valve looks larger.
Yeah.
So Gareth, if you've done this with an S3, would you have pre-stented as well?
I think given
this
the amount
particular
of
case?
RVUT muscle, I think you had to.
I actually, if it is for an S3, definitely I will pre-stent, because I don't know whether S3 is good enough for this infundibular stenosis. Only after I put in the PAMAs, I came to know that it is easily dilatable. I was anticipating that it may be a very fibrotic infundibulum. Now, okay, let us do one thing. Let's get a marker picture. Marker picture.
Shiva, Salim's got a question for you.
Hi, Salim.
Hi, Siva, Salim here. Very good case. So actually, the question is for the audience as well, or the panel. You know, you said that you can mount 2 stents on a melody valve. Is the balloon strong enough to open all of these stents at one go? It seems like you're struggling to open this one.
No, I think the reason this one struggled is because the edge of the balloon was over the tips of the ensemble balloon. So as long as it's not too long, then the balloon's strong enough to open it.
Yeah.
You do have to go up a bit higher in the atmospheres, as in you need to take it up a couple of extra atmospheres before it starts to open. But if you're willing to do that, it opens up with 2 extra stents.
Yeah, it will. It'll open.
And I think regarding the S3, I think the problem, to be honest, Brian, here with the S3, it might have been
Second
just too
pressure
short,
line.
and it might have been a very difficult deployment. I think I would
Get me another 5 French picture.
for that reason.
Gareth, I think it depends on what the level of stenosis is, isn't it? I mean, if you have a very severely stenosed conduit, even with the bib balloons
This is a
are
6
the
French.
same
Do we have
for the ensemble.
Okay, get
so
me
beyond
a
4.5,
five-
the outer balloon is going to rupture. So invariably, you end up for stenotic lesions. You need to use an atlas for post-dilatation.
Yeah, I mean,
Absolutely. I think Salim's comment was more, is it
Come to
strong enough
APV?
to open the stents in
Initial
there?
implant.
Put it on 50
and
40
obviously,
scale.
a highly stenotic conduit's different than a native
Put it on 40
outflow or
scale.
a patched outflow tract.
Keep going.
Can I ask a question just
Show-
about the
show
position
below.
of the
Show below.
melody and the Zephyr stent? Why didn't you put it a little further back so that it kind of covers the outflow better? Because the bit which is going to break
below.
is in the outflow tract, and that's just got a single stent in it now.
I didn't understand the question. What was it?
So Radwa was asking very important technical question, which is why didn't you implant the valve a bit more proximally in the stent?
Okay, the proximal end I had actually flared it. So if I have a flared stent and then I put in a melody, now I'm going to have a redundant one cul-de-sac. So in fact, I wanted it to be a little bit more distal. You get it, Redva? See, I will show you now on a fluoroscopy. Go to epicranial. Go to epicranial.
Also, without flaring, if you don't inflate the melody up to that diameter, or not enough, then there's a risk of proximal migration, isn't there?
The reason for dilating the flaring out the proximal end was to allow my ensemble to go easily without getting crimped. Now you see this picture now. But you see this picture. Come down. Now I'm taking a cine. See the proximal portion is actually flared. I have only dilated to 24. So if I dilate to 24 at the bottom end, I will have a surrounding layer like a dead space. So I wanted to push it a little bit more distal. Now second thing is, now the hemodynamics. Get the hemodynamics big. Hemodynamics big. Okay, so this is the LV to this is the RV to PA pressures. So now it looks okay to me. There is actually the right ventricle is a little like underdamped. So there is a sharp flicks.
But that's a good result.
Now you see that I have actually damped it a little bit by aspirating some blood. It was otherwise if I leave it to full, it is a little underdamped and see that's a overshoot.
Shall we do an angiogram?
Yeah,
then you can move on to your next patient.
Yes. So this is the hemodynamics. Hemodynamics big once again, and then I'm going to angiogram. Get ready, angiogram. So this is the LV to aorta. Now I'm going for an angiogram. Come, 25 ml, 15 rate, 1000 psi. 25, 15,000 psi. Is this too much magged? I want less mag. Zero mag. Okay, come down then. Come down on the table. Yeah, ready for an angiogram. 25, 15. How much time, Shaq, we have?
No rush.
Okay, it looks good, Shaq. Actually, there is not much of PR.
Brilliant.
Okay, now let me see. Give me thermo wire. Let me review this angiogram. Not much of leak, Shaq.
Is there a lateral as well, or?
Okay, I will do a lateral. Actually, ours is, you know that it's a monoplane, but I can give you another contrast. I was not very keen on giving another contrast. But are you not truly satisfied, Shaq?
Yeah, no. Pigtail a little bit lower and lateral.
Okay.
Steve, I don't think you should listen to him. I think it looks great. He's just
Shaq,
teasing.
Shaq wants what he wants to get. Okay, he gets what he wants to get. Come to lateral, please.
Shaq gets what he wants.
Yeah, he get what he wants. So come.
Alison's making the point that it might be nice just to go very
Lateral.
caudal and look at the circularity of the valve frame, and you wouldn't need to give any contrast for that.
Actually, I have recorded with the marker pigtail to find what is the recoil. I will ask somebody to measure it. Is there somebody who can measure it ready for an angiogram? Should. Looks good,
Brilliant.
Shaq.
Yeah, absolutely. I agree with that. Excellent
That's
result.
fantastic.
So somebody will measure soon. Like in order to avoid wasting time.
And you've got 2 minutes to go on and do your next case.
Yeah,
Don't worry, it's only a
I'm
sinus
going.
stenosis
Actually,
ASD.
the plan here will be a figure of 8 on the right groin and then come out. So I'm moving to the next lab.